In the webinar today, we'll be discussing response strategies to diphtheria outbreak in the World Health Organization African region. And this has become one of the key issues we really need to discuss at this time. A couple of countries within the African region is currently responding to diphtheria outbreak, and we know that the risk for diphtheria outbreak in other countries is high. Hence, the need for this webinar for information sharing for member states to be able to prepare and respond appropriately. So before we start this session, kindly note that this virtual training adheres to the WHO training, to the code of conduct to preventing harassment, including sexual harassment at WHO events. We'll be going through this agenda in the next 2 hours. My name is Dr. Laulu Aderiola. I support the PHUC at the regional office in Brazzaville for diphtheria. Following this, we'll have the incident manager of the diphtheria response in the African region, Dr. Patrick Otim, taking us through that. This will be followed by an overview of diphtheria in the African region, taken by Professor Andre Peter, who is the head of operations and technical expertise, and will be followed by surveillance by Dr. Ineza Thierry, and laboratory will be taken by Dr. Musa Hindeye. We'll have a brief pause for question and answer before we now move into case management, which will be taken by Dr. Rashidatu Kamara. Infection prevention and control will be taken by Dr. Deborah Barasta, and immunization will be taken by Dr. Jules B. We'll have a short question and answer, and it will now be wrapped up by Professor Ola Olainka. So for us to enjoy this session, use the question and answer feature for questions regarding the topic and presentations. So only questions in the Q&A will be answered during the sessions. Live sessions will be taken at the end of all the presentations. Use the chat feature for questions regarding IT, logistics, and probably just introduction when you join this session. Interpretation is available in English, French, and Portuguese by clicking the interpretation button. So click on interpretation and choose the language that you would like to hear. To hear the interpreted language only, click mute original audio. There is live transcription for this webinar. Click on show captions and caption will appear on the screen. To close the caption, click the hide captions. This session is being recorded, and we take your attendance as consent to be recorded. Recordings will be shared after the session in English, French, and Portuguese. Session materials, including session recordings, will be emailed to participants in the days following the webinar. As we continue to improve our training programs, your feedback is invaluable to us, and the survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will also help us to tailor future sessions to better meet your needs and expectations. I'll now call on the incident manager of the diphtheria incident management support in the African region, Dr. Patrick Otim, to give his opening remarks. Over to you, Dr. Patrick.
Thank you very much, Dr. Olaolu. Good morning, colleagues. Thank you for joining us this morning once again on one of our webinar series. This morning we will be discussing strategies for responding to diphtheria within the WHO African region. I think from the onset, I would like to begin by thanking all member states for the progress that has been made. I think we all have to acknowledge that significant progress has been made within our region in terms of prevention of vaccine preventable diseases. milestones have been achieved in the polio eradication, and access provision of health services have also improved, and we have seen that life expectancy has also improved in a number of the countries. However, we are faced again with one challenge, one significant public health challenge that is coming up, which is the outbreak of diphtheria. Diphtheria, as we know, is a highly contagious and potentially very deadly bacterial infection. Those days we used to say that diphtheria is one of the 6 killer diseases of children in the early childhood. It along with measles, diphtheria, tetanus, tuberculosis, and polio were those diseases that were classified as the 6 childhood killer diseases. In most parts of the world, diphtheria has largely been controlled. Actually, from the mid of the 20th century, when vaccines were introduced, there was a marked decline in the number of cases of diphtheria and outbreaks that were being reported. However, in the last few years, we are seeing a resurgence of diphtheria, and largely it is due to vaccine hesitancy. It is due to a weak health system and gaps in immunization coverage. And therefore, it really calls for countries to scale up their vaccine coverage. We look at analysis from the WHO UNICEF estimate of the national immunization coverages for 2022. We can see that there are a number of countries within our region who are falling far, far below the ideal threshold of at least 80% coverage of either the third dose of the pentavalent vaccine or the third dose of the DPT in countries which are still using that. And you will see that the coverages in many countries are below 80%. And this therefore means that these countries are at risk of diphtheria outbreak. Currently, we have active outbreak in 3 countries in West Africa, and even the surrounding countries and some of the countries in the southern and eastern part of this of our region are at risk because of this low coverage. I have 2 last messages to end with. One, why is this outbreak of concern right now? This outbreak is of concern right now because of the impact of COVID-19 pandemic that disrupted provision of routine services, disrupted immunization activities, and this has resulted to a buildup in the cohort of what we describe as 0-dose children who have yet to receive even the first dose in the series of the DPT or the penta vaccination. So this cohort has been increasing in a number of countries, and it's a big, big concern. The second issue is that we have early features of antimicrobial resistance that have been detected in this particular outbreak. The bacterium has shown that in one of the countries that there is high levels of resistance against penicillin, which is one of the antibiotics that is commonly used for management of this disease. There's also resistance emerging in another country to erythromycin, which is the next antibiotic that has been put in line. So it's a very, very big concern that we have a bacterium that is causing an outbreak that is resistant to the commonly used antibiotics, and we have to really respond aggressively and contain this. The other issue is that because this disease had already largely been contained, the production of the diphtheria antitoxin, which is used for management of severe cases, had largely been curtailed in most of the countries because it was no longer viable. There were no outbreaks, so most of the manufacturers were not seeing any economic sense in producing that. So we have very limited supply of the diphtheria antitoxin, which is required to manage severe cases, and therefore we are likely to see high mortality. And lastly, there is also limited supply of the vaccines if we have to do routine coverage, particularly because we have to do reactive vaccination, particularly because we are seeing cases also not only in children below 5 years, but also in children above 5 years. So the target group to be vaccinated is increasing, and therefore it puts a lot of pressure on vaccines that are required. So my final message to colleagues is that, one, we really need to advocate and engage in our countries to scale up the routine immunization coverages to really above 80% where possible, and also ensure that the zero-dose children, we reach out to them and we leave no child behind. Secondly, we need to improve surveillance, and this is one of the reasons for this webinar, that we are able to get the skills for surveillance. We are currently updating the IDSR guideline on diphtheria surveillance so that we can be able to prioritize it, because previously it was not one of our priority diseases. We have to bring it back to focus. And then thirdly and lastly is to improve clinical management. We have seen a number of deaths already reported in the 3 countries that are affected, and we need to get the skills so that we can be able to effectively manage the severe cases and reduce mortality. So I wish you a very nice deliberation in this session, and please share the information with the other healthcare workers within your countries so that we can be able to improve the level of awareness as well as the skills in managing this disease. Thank you very much, and I look forward to the deliberations and interactions during this webinar.
Thank you so much, Dr. Patrick, for really setting the tone for the essence for this webinar. We can see the issues we are dealing with. The vaccine coverages are low. We have issues of inadequate vaccines to be able to vaccinate children that are supposed to be vaccinated. We are also still dealing with the postmortem of the COVID-19 pandemic. So we have quite a lot to really discuss, and to move on with this webinar, I'll call on Professor Andre Peter, who is the head of operations and technical expertise, to take us through the overview of diphtheria. Over to you, Professor Peter.
Thank you very much for giving me this opportunity to talk to over 300 participants. So it's a real privilege to present overview on diphtheria. So for equity, I have prepared this presentation in English, but I will speak in French for equity. Donc, comme je disais, c'est véritablement un privilège de parler à plus de 300 personnes sur le sujet qui est la diphtérie. Ma présentation va être une présentation générale, des généralités. Il y aura des présentations spécifiques par la suite sur le laboratoire, la prise en charge des cas, la prévention. Donc, dans un premier temps, je vais faire une introduction, mais Patrick vient juste de faire une introduction qui est très bonne. Puis, l'épidémiologie. Je vais parler de la transmission, de la transmissibilité, du réservoir, de l'incubation, de la pathogénèse, et y compris l'immunité. Je vais juste énoncer des éléments sur la présentation clinique, les complications, diagnostic différentiel, le labo, et la prise en charge, juste des éléments, parce que juste après moi, il y aura des présentations en détail, et lors des discussions, on pourra rentrer dans certains détails. Alors, la diphtérie est une maladie aiguë qui est transmise au niveau de la partie respiratoire supérieure et qui est causée par l'espèce Corynebacterium. Et il faut dire que ce qu'on a le plus, qui fait le plus de maladies, c'est le Corynebacterium diphtherie, qui produit une toxine. Alors, cette maladie affecte les muqueuses de la partie respiratoire, comme je disais, également la peau et rarement les muqueuses en dehors de la peau, mais on peut retrouver ce cas au niveau génital, au niveau de la conjonctivite et même parfois au niveau systémique. On peut également dire, et vous allez voir tout à l'heure avec la pathogénèse à partir de l'absorption dans le sang et sa diffusion, qu'on peut avoir des complications dans tous les autres organes comme le cœur et au niveau nerveux. Mais il faut dire que l'utilisation de l'antitoxine a véritablement amélioré le traitement et l'extension de cette maladie, et y compris la vaccination avec l'anatoxine. Ça a véritablement réduit la morbidité et la mortalité, comme ça a été présenté tout à l'heure. Il faut également dire que c'est une maladie dont il y a quelques années, il y a pratiquement deux décennies, on n'a pas eu beaucoup de cas, mais c'est une maladie qui affecte plus les enfants et la fréquence de plus en plus depuis plus de 2000 est en train d'augmenter. Et on peut dire qu'avec tous les efforts qui ont été faits au niveau du système de santé, il y a eu cette réduction, notamment la vaccination. Mais comme il a été dit, la réduction, la qualité de notre vaccination et la pandémie à COVID a malheureusement réduit l'immunité, surtout des enfants, et a entraîné, comme on le voit maintenant, des épidémies. Alors, l'incidence a baissé, mais malheureusement, on peut voir des cas. Et vous allez vous rendre compte tout à l'heure que chaque année, il y a des cas, mais malheureusement, il y a une petite confusion parfois dans le diagnostic, mais on finit par éviter des épidémies à cause de la couverture. Alors, donc, comme je disais, ça reste endémique, surtout dans les pays où la couverture est faible, la couverture vaccinale, notamment en Afrique. Et on a des cas actuellement d'épidémie au Nigeria, au Niger, en Guinée. Il y a quelques cas dans des pays comme le Cameroun, le Mali, l'Angola. Alors, il faut aussi dire que globalement, on peut retrouver, mais on a eu des cas dans le passé où on avait pratiquement tous les 15 ans de très grandes épidémies. Alors, lorsqu'on regarde un peu, on se rend compte que malgré tout, il y a quand même des enfants vaccinés qui font la maladie. Mais globalement, on tourne autour de 70% d'enfants qui n'ont jamais eu de vaccin ou qui sont moins vaccinés. On voit par exemple qu'en Guinée, toutes les personnes affectées n'ont pas été vaccinées. Alors, il faut dire qu'entre 2010, quand on regarde un peu l'épidémiologie, entre 2010 et 2020, il faut quand même dire qu'en Afrique, on a pu en moyenne rapporter plus de 2000 cas suspects de diphtérie. Et malheureusement, ce n'est que cette année qu'on a eu des épidémies majeures, comme on a pu le constater. Il faut dire que la saisonnalité est pas vraiment importante, mais parce que les cas le plus souvent sont bénins. Et peut-être c'est pour cela qu'on n'a pas l'impression, malgré les 2000 cas, qu'il y a véritablement que c'est un véritable problème de santé publique. Alors, j'ai juste pris quelques schémas, notamment le Nigeria. Vous voyez, il y a eu, c'est l'épidémie majeure, mais il y a une réduction des cas depuis un certain temps. La Guinée également, là-bas, on a plus de 10 000 cas suspects. En Guinée, c'est plus de 200, mais la maladie est en train de croître. Au Niger également, la maladie est en train, on a plus de 700 cas. Et depuis le début de l'année, pratiquement plus de 1000 cas. Alors, concernant la transmission, il faut dire que la transmission se fait de personne à personne à travers le tractus respiratoire. Et on a également, c'est surtout relevé par le portage. Rarement, on a des transmissions au niveau des membranes. Alors, il faut aussi dire qu'on peut l'avoir, mais c'est véritablement rare au niveau des membranes. Alors, le risque véritable pour pouvoir avoir une épidémie, comme l'a dit Patrick tout à l'heure, c'est véritablement une faible protection des immunités des enfants, parce que c'est les plus atteints, mais surtout une hygiène qui est très faible, Et parfois, comme recommande l'OMS, certains enfants sont vaccinés, mais on peut recommander des doses pour pouvoir relever des doses booster. Alors, concernant la transmissibilité, il faut dire que même lorsqu'on ne fait pas la maladie, il y a un portage qui est là et on peut continuer au niveau du tractus supérieur, on peut continuer à transmettre malgré ce fait. L'antibiothérapie qui est faite très tôt permet de réduire cette transmission. Voilà pourquoi il est recommandé de donner des antibiotiques parfois à titre prophylactique ou alors pour pouvoir éviter l'extension. Le réservoir, comme vous le savez, ça reste l'homme, le réservoir naturel. Et comme je disais, surtout le portage, c'est un facteur qui favorise. L'incubation peut se faire entre 1 et 10 jours. Entre 1 et 10 jours. Concernant la pathogénèse, il faut dire que l'exotoxine qui est produite par Corynebacterium diphtheria est le facteur le plus important qui est associé aux organismes. Alors, cette toxine va inhiber la synthèse des protéines et va causer des dégâts au niveau cellulaire, et ce qui va entraîner ces muqueuses qu'on va pouvoir retrouver. Et donc, ces muqueuses vont durcir et vont avoir un caractère qui ressemble au cuir. C'est le caractère que vous allez voir qu'on retrouve au niveau des muqueuses. On peut avoir une absorption de la toxine au niveau de la circulation sanguine et ça va affecter par la suite les autres organes. C'est comme ça qu'on aura des complications comme des diphtéries au niveau cardiaque ou bien au niveau des reins et encore des nerfs. Concernant l'immunité, et comme ça a été relevé, la protection vaccinale reste la meilleure. Il faut dire qu'on peut également être immunisé parfois sans avoir absolument fait la maladie. Donc, la vaccination par la toxine diphtérique reste celle qui protège. Et vous allez voir tout à l'heure, lorsqu'on va présenter la vaccination, qu'il y a véritablement une immunité qui peut être longue, mais pas à vie. Une immunité longue, mais pas à vie. Et il faut aussi dire que il faut qu'il y ait une certaine couverture faible, comme le disait de moins de 80, pour réduire une immunité communautaire et favoriser la transmission. Mais comme vous avez vu, il y a beaucoup de cas. Mais le fait que parfois ce soit des cas bénins fait en sorte que ça peut passer inaperçu. Alors, concernant les aspects cliniques, encore là, je vais juste donner quelques éléments, je ne vais pas entrer dans les détails. Tout va dépendre de la localisation de la maladie. Mais il faut dire qu'on peut avoir des températures qui sont basses, qui n'excèdent pas 38,5 degrés. Et comme je disais, dépendant de la localisation, il faut aussi dire que de temps en temps, on peut avoir une légère, de quelques symptômes. C'est lorsque ça complique qu'on a cette impression. Donc, c'est une maladie insidieuse qui se présente de façon insidieuse, de façon aiguë. Et au fait, selon la quantité de toxines, ou alors selon l'absorption dans le sang, on aura donc cette complication, notamment cette fatigue qui est souvent aperçue et quelques troubles respiratoires. Alors, on peut classifier dans la diphtérie selon, comme je disais, selon, on peut avoir une diphtérie nasale, pharyngique, ou alors laryngique ou bien cutanée, quelques rares fois. Alors, les complications, comme on disait, ça peut être au niveau du respiratoire, notamment avec l'obstruction respiratoire, ou alors des myocardites. Mais il faut dire que ce sont des complications parfois rares. En termes de différentiel, et c'est là où parfois ça peut passer inaperçu, parfois ça peut être confondu aux infections virales au niveau du pharynx, ou alors des angines, surtout l'angine de 25 et autres infections orales. Tout à l'heure, vous aurez les détails encore lors de la présentation sur la prise en charge des cas. Concernant le laboratoire, il faut dire que les prélèvements au niveau du tractus, au niveau de la bouche peuvent être faits. Et ce qui est très important, c'est qu'il faut faire de la culture. C'est véritablement essentiel. On fait de la culture, on peut faire aussi de la PCR. On peut mesurer même la toxicité. Le Gram-Stem n'aide pas beaucoup ici, là. Tout à l'heure, vous allez voir dans les détails également du laboratoire les différents éléments qui permettent de le faire. Alors, ce qui est important en termes de prise en charge, c'est rapidement reconnaître et traiter la diphtérie. Vous avez vu la différente présence. Elle est insidieuse, parfois elle peut être confondue, mais si elle peut être reconnue très rapidement, surtout lors des épidémies, c'est une très bonne chose. Il faut hospitaliser les patients, il faut les isoler. Tout à l'heure, vous allez voir les détails par rapport à ça. Comme la maladie est véritablement contagieuse, il faut les isoler. Alors, on a rarement des complications. On l'a vu tout à l'heure. Alors, concernant le traitement, le meilleur traitement, c'est l'anatoxine, l'antitoxine diphtérique, qui est rare, mais il faut aussi dire qu'on peut donner des antibiotiques, mais ça ne remplace pas en termes de qualité le traitement. Il y a également l'infection, la prévention et le contrôle. Tout à l'heure, il y aura une présentation par rapport à ça. Il faut véritablement s'assurer de l'hygiène parce que les personnes aussi qui prennent en charge les cas ou bien les contacts sont véritablement à risque à cause du caractère de transmissibilité. Alors, on l'a dit depuis le début, Patrick l'a mentionné, la vaccination reste l'intervention importante. Lorsqu'on a eu les 3 vaccins avec l'anatoxine, il y a une longue protection, mais l'OMS recommande aussi les doses booster jusqu'à 5 ans. Mais il faut dire que rarement on les a dans notre contexte. Peut-être qu'il faudra revoir avec la résurgence quand on sait qu'aujourd'hui, on a des enfants de plus de 5 ans, parfois jusqu'à 14 ans. On a vu dans certains pays comme au Nigeria, entre 1 et 14 ans, on a pratiquement 70% des enfants qui sont malades. Donc, il faudra faire des analyses profondes pour véritablement savoir quels sont les enfants à risque. Comme je dis, on peut faire l'antibiothérapie prophylactique également. Donc, je ne vais pas revenir sur la vaccination. La vaccination routine va être véritablement importante. On connaît les couvertures qui sont attendues au moins 90, mais si on a 95, c'est encore une très bonne chose. Donc, il y a d'autres opportunités de vaccination qu'il faut effectivement saisir. Actuellement, on est dans le grand rattrapage, le big catch-up, où véritablement il faut profiter pour pouvoir réduire justement ces enfants qui sont vulnérables à cette maladie. Donc, j'ai rappelé un peu la position de l'OMS. On reviendra dans les détails par rapport à cela lors de la prochaine présentation. Alors, concernant l'épidémie, il faut dire que c'est parfois difficile. Vous avez vu, on a pratiquement plus de 2000 cas depuis une dizaine d'années, mais on ne parle pas d'épidémie. Alors qu'il faut qu'il y ait un cas confirmé avec un lien épidémiologique pour parler déjà d'épidémie. Mais comme la maladie est bénigne, parfois on ne se rend pas compte de ça, contrairement à ce qu'on a actuellement. Je vais juste donner les éléments de contrôle. Il faut une bonne surveillance, il faut une très bonne vaccination dans le contrôle. Elle peut être préventive, elle peut être réactive lors de l'épidémie. Il faut également reconnaître rapidement la maladie avec une bonne prise en charge des cas, de bonnes investigations, une bonne prévention et contrôle de l'infection. Il faut également une bonne communication du risque et l'engagement communautaire. Et bien évidemment, et on l'a vu actuellement, le manque de moyens pose un problème. Il faut également mettre la mobilisation des ressources. Il y a quelques références qu'on a pu donner. La présentation, comme on l'a dit, sera aussi en français et en portugais. Sur ce, je vous dis merci beaucoup. Merci.
Oh, great. Thank you so much, Professor Bita, for taking us through that overview and also keeping to time. He has highlighted the challenge that we really face in the African region, the challenge of zero-dose vaccination, reduced herd immunity. The countries that are battling with the diphtheria outbreak at the moment, Nigeria, Guinea, and Niger, and steps that we need to take for outbreak control. He has given a great synopsis of what we are going to have in this, and we'll continue the presentation with two sessions that will be coming on surveillance and also on laboratory. So we'll have Dr. Ineza Thierry that will be taking us through the surveillance aspect, and we have Dr. Musa in there that'll be taking us through the laboratory component. So colleagues, your questions, kindly put it in the Q&A chat so that panelists can respond to those questions appropriately. Thank you, and Dr. Eneza, over to you.
Okay. Thank you, Olaolu, for introduction, and good morning, colleagues. Good afternoon, good evening from wherever you are. And I'm Dr. Thierry Neza from EPR, Emergency Preparedness Response Cluster in WHO AFRO in Brazzaville. So I will present you surveillance of diphtheria. So the plan that we'll be following, we start by introduction, followed by objectives of diphtheria surveillance, recommended type of surveillance, case definition, case investigation, contact tracing, surveillance in outbreak settings, and we finally see recommended surveillance performances indicators. So diphtheria transmission is most often person-to-person spread from the respiratory tract. Toxigenic diphtheria is vaccine-preventable disease, and due to success of immunization programs in several countries, coupled with good diphtheria toxoid vaccine coverage among population, diphtheria has become rare in several countries. This may result in several unrecognized diphtheria cases by health professionals and delays in case investigation, contact tracing, and other public measures to prevent its spread. Public health measures of diphtheria case might involve case investigation, contact tracing, in addition to other public health measures. We need to note also that during wide-scale outbreaks, as mentioned, diphtheria became very rare. We need really to have in place all those case investigation, but sometimes available means cannot be enough to do case investigation, contact tracing. So objectives of the surveillance system is to monitor disease burden and define transmission patterns, identify outbreaks to trigger investigation and prevent further cases, to determine appropriate vaccine policy in country, such as the need to introduce boosters. So for the surveillance type which are recommended, first, they can be facility-based surveillance as we all have in our countries, but also as the disease has become exceptional in some countries and some areas, it's recommended to have case-based surveillance. This requires health workers to be able to identify diphtheria cases. So all the identified diphtheria cases need to be notified to the surveillance system. And ideally, it's recommended to have a laboratory confirmation at all identified cases of diphtheria. Also, we need to note that during large outbreak, lab testing of all suspected cases might be logistically unrealistic, and that countries can adapt their surveillance systems. So let's look to the case definition. Suspected diphtheria case is any person with illness of upper respiratory tract with pharyngitis, nasopharyngitis, tonsillitis, or laryngitis, and adherent pseudomembrane on the upper respiratory tract, like as it showed in the picture on the top right. And it's important to mention that some countries also can choose to expand the suspected case definition to include mild cases without a pseudomembrane or cases with no healing ulcers with a travel history to countries with endemic diphtheria or countries with diphtheria outbreaks. So on the right side, we have also a picture showing an ulcer in the patient. So for laboratory confirmed cases is defined as any person with Corynebacterium diphtheria isolated by culture and positive to toxin production, regardless of symptoms that case can present. The toxigenicity of the strain must be confirmed by the phenotypic ELEC test in all instances to be able to say that the case is infected with Corynebacterium diphtheria, as Prof. Bita said recently. So laboratory confirmed cases may be further classified into 3 subcategories based on the type of surveillance occurring in the country. They can be cases with classic respiratory diphtheria, which meet the suspected case definition and are laboratory confirmed as above mentioned. They can also be cases with mild respiratory diphtheria, which have some respiratory symptoms such as pharyngitis or tonsillitis, but without a pseudomembrane as showed in the previous picture. And they can be also asymptomatic cases, but mostly those cases in these subcategories, they are identified via contact tracing. And this makes me emphasize really that in surveillance system, we need to have a good case tracing system. Lastly, they can be classified as non-respiratory laboratory confirmed cases, which have a skin lesion or non-respiratory mucosal localized, for example, in eye, in ear, or in genital organs, from which Corynebacterium diphtheria is isolated by culture and was tested positive for toxin production. In third position, cases can be classified as epidemiologically linked cases. That means that the definition of a suspect, they meet the definition of suspected case and is linked epidemiologically to a laboratory confirmed case. Also, this means that the person has had intimate respiratory or physical contact with a laboratory confirmed case within 14 days prior to onset of sore throat. So case can be classified as well as clinical compatible case. This means that they meet the definition of a suspected case and lacks both a confirmatory laboratory test results and epidemiologic linkage to a laboratory confirmed case. Also, we can classify a case as discarded case, which means that the case either has Corynebacterium diphtheria isolated, but on ELEC tests, it was negative ELEC test, meaning that the person is infected by a non-toxigenic Corynebacterium. Another possibility also, we can have a PCR negative for diphtheria toxin. So to define diphtheria cases, we will sum up laboratory confirmed cases, epidemiologically linked cases, and clinical compatible cases. So this algorithm, I'm not sure if you can see it clearly, but mainly it gives the same information than what was said previously, and the final cases on the final case classifications. So first, we have a suspected case meeting the case definition with 2 possibilities. Either the sample was collected and sent to the laboratory for analysis. And this is the scenario on the top left side. Or another possibility, we can have a suspected cases without any laboratory specimen collected and sent to the laboratory. And this is the scenario on the left bottom side. So for the suspected cases, with sample collected, we will have 4 possibilities. First, the culture is positive to Corynebacterium and negative toxogen on ELEC tests. So then we have an infection with no toxigenic Corynebacterium. This will be classified as a discarded case. Second possibility, we can have a culture, negative culture for Corynebacterium diphtheria, and ELEC test is negative as well. This also will be classified as a discarded case. The third possibility is that we have the culture, negative culture for Corynebacterium, and PCR is positive for toxogen, or the PCR was not performed. In this case, we have also 2 possibilities. Either this is a contact case with a laboratory confirmed case, then it will be classified as an epidemiologically linked case, or the second possibility, this not a contact case. Then we will have to review the epidemiologic picture and classify the case on case-by-case basis. So in this last case scenario, we need to be sure that either the antibiotics were not given prior to sampling the patient, or the condition of sample handling and timely transportation of all those samples to the laboratory were not met, and this can affect, bring the false negative results. So we really need, whenever we have this case scenario, we need to make sure that no antibiotic was given prior to sampling, and that we met all the conditions for laboratory sampling, handling, and transportation. So the fifth possibility, the fourth possibility is that we have culture positive to Corynebacterium diphtheria, and ELEC is positive. So that is, we have toxogen Corynebacterium. So in this case, we will classify the case as laboratory confirmed case. So on the right side in the middle, the algorithm tells us that we have contact cases that are positive both to ELEC tests and to culture with Corynebacterium diphtheria identified on culture. So this contact case will be classified as a laboratory confirmed case. And in the middle, they gave us how all the laboratory confirmed cases can be classified in 3 groups as detailed previously, so I will not go through them. Lastly, on bottom, for suspected cases for which sample was not collected and sent to the laboratory, either there will be history of close contact with lab confirmed cases, then they will be classified as epidemiologically linked case. Or second possibility, there will be no history of contact with a confirmed case, then they will be classified as clinically compatible cases. So for case investigation, we need to emphasize that clinicians seeing diphtheria, suspected diphtheria cases in their consultation need to notify them to public health authorities within 24 hours. And this also is to allow that health authorities can arrange diphtheria antitoxin to be provided to the patient. On the other side, on their side also, the public health authorities should investigate the case within 48 hours of report regardless of the case vaccination status, whether it's vaccinated fully or had some diphtheria containing vaccine. All those cases, or is not vaccinated, all those cases need to be really investigated within 48 hours. So, as mentioned, the most important surveillance system in diphtheria, it's case-based surveillance, and we need to fill in investigation form for all the cases, suspected cases, and for all contacts that were identified. All suspected cases should be isolated and have 2 specimens collected, one in nasal and another one pharyngeal swab over and around the edges of the pseudomembrane. And this is said to be done prior to giving antibiotics. So on the bottom of the slide, we are giving a link where you can get an example of case investigation form that each country can adapt to its context. And also, if needed, modification can be made to the case investigation form to capture new risk factors that any country can find. So case investigation form should be completed for every identified close contact as stated previously, and information on contact must be recorded separately of those of the cases. Contacts should be closely monitored for occurrence of symptoms within 10 days after the last test contact with suspected cases. And at the minimum, close contacts are defined to be household members, and they can also be caretakers, relatives, sexual contacts, fellow students, and friends who regularly visit the home of the case. It can also be the medical staff that were exposed to case oral or respiratory secretions or exposed to their wounds. And on case-by-case basis, the list of the contacts can be expanded. My slides are not moving. Okay. So, if the scale of outbreak and available means allows it, surveillance system and surveillance staff should communicate daily with contacts to monitor for new symptoms. 2 samples should be collected from every suspected cases at first contact with the health system. And this includes, as I said, pharyngeal and nasal swab. Ideally, all samples should be sent to the laboratory within 24 hours of collection and arrive at the laboratory within 2 days after collection. We also need to emphasize that the delays in the sampling or sending the sample to the laboratory may compromise the ability to isolate the diphtheria on culture. So how we define diphtheria outbreak? A single laboratory confirmed case of diphtheria should trigger a public health response. 2 temporary and geographically linked cases, of which at least 1 is laboratory confirmed, is considered to be a diphtheria outbreak. And we need also to emphasize that during outbreaks, additional cases can be identified using clinical diagnosis based on the suspected case definition given previously. And also, we need to emphasize that whatever, even if the public health authorities, they expand the case definition, but we really recommend that laboratory investigation should be performed to all suspected cases whenever it's possible. So depending on the size of outbreak, a country can choose to not test all suspected cases to avoid overwhelming of the laboratory. So in this situation, the definition of an epidemiologically linked case can be extended to include linkage to another epidemiologically linked cases rather than defining it according to a laboratory confirmed case. So this chain should only continue for approximately 2 to 3 incubation periods. This means that around 3 weeks, at which point any cases identified should be tested to confirm the outbreak continues to be toxigenic diphtheria. Once 5 cases are confirmed to be toxigenic diphtheria, epidemiological linkage to other epidemiologically linked cases can be carried on. Otherwise, we need to think that maybe the outbreak has stopped expanding. Also talking about outbreaks, for outbreaks lasting for an extended period, at least 5 samples should be tested by culture and elect test every month among suspected cases with no epidemiologic link to a confirmed case. So in very large outbreaks, case-based surveillance and contact tracing may no longer be feasible and aggregate surveillance may be done instead. So countries should make their decision based on epidemiologically and available resources, which can be human resources, availability, financial resources, or logistic available in the country. Case-based surveillance is always advised and the best because contact tracing and post-exposure prophylaxis can be a life-saving prevention strategy. So the three following slides give details on recommended surveillance performance indicators, and I will not go through all of them, but mainly they are adequacy of investigation, timeliness of investigation, specimen collection, timeliness of specimen collection, toxigenicity testing rates. Can also look at the timeliness of specimen transport and also at the timeliness of reporting laboratory results to health facilities. So to conclude, diphtheria has become a rare in several countries, however, remains endemic or epidemic in some areas with low diphtheria toxoid vaccine coverage. Case-based surveillance is recommended and requires health workers to be able to identify diphtheria cases. Effective case investigation plus contact tracing are key to outbreak control. And during wide-scale outbreaks, the surveillance system will need to be adapted to its scope and to available means. And lastly, surveillance should be evaluated at least once a year to ensure that the country is able to meet the objective of the surveillance accurately. So thank you for your attention. Merci beaucoup. Over to you, Olaolu.
Thank you so much, Dr. Thierry, for that presentation. In the interest of time, we'll quickly move to Dr. Musa Hinde to take us through the presentation on the laboratory component of this response. Dr. Musa, over to you. And colleagues, continue to put your questions in the Q&A chat. Thank you.
Good morning, good afternoon, good evening to everyone. On behalf of the IVB team, I want to really thank everyone for joining us today to be part of this nice webinar. In the next few minutes, we'll talk about diphtheria laboratory diagnosis. My name is Musa Hinde, and I'm a diagnostic microbiologist. And I work side by side with Dr. Mulders, and we are part of the laboratory team. In the next 15 minutes or so, we're going to talk about the pathogen that all our colleagues talked about, how we collect the samples and how we transport them to the lab. We'll talk about how we culture the toxigenic Corynebacterium, how we identify it with simple methods to more advanced methods. Then we'll talk a little bit about the antimicrobial sensitivity testing and its importance and the standard protocols that are available. We'll talk a little bit about how we identify the presence of that toxin inside the Corynebacterium. And we'll finish up talking a little bit about how we test for population immunity and susceptibility to diphtheria. Now, the first thing we talked all of us about the toxigenic Corynebacterium, and it's really important to know that there are 3 genuses in the family of Corynebacterium that are toxigenic, and means they can produce the tox gene. These are the Corynebacterium diphtheriae, Corynebacterium ulcerans, and pseudotuberculosis. We're going to concentrate on the Corynebacterium diphtheriae and ulcerans and pseudotuberculosis. Mainly these are they cause zoonotic infections, and we will not talk in depth about them. But we'll talk about Corynebacterium diphtheriae. And it's important to know that Corynebacterium diphtheriae has 4 biovars, which means that there are 4 different biochemically and physiologically different types of Corynebacterium. These are the Corynebacterium diphtheriae, biovar gravis, mitis, intermedius, and wolfentii. Now, all of you guys might think, how come this Corynebacterium produces the toxin, or where does it get the toxin from? It's important to know that Corynebacterium acquires the toxin after being infected with a bacteriophage. So what you see on the right of the screen is a bacteriophage. It's called a beta-phage that has the tox gene, and it infects the Corynebacterium diphtheria, and then the Corynebacterium diphtheria starts producing the toxin that is associated with all the clinical presentations that our colleagues talked about. Now, a lot of our colleagues talked about the most important thing in the diagnosis of diphtheria, and that's specimen collection and transport. This is really a pillar in making sure that we diagnose diphtheria accurately. So collection of oropharynx and nasopharynx samples, it's very important. Also, we can have samples from the ear or wounds if we have cutaneous diphtheria, as you can see on the right. The samples, the oropharynx and nasopharynx samples should be collected right at the onset of symptoms, right before antimicrobial or anti-toxin therapy. If the patient has a pseudomembrane, as you can see in the slide in the middle, a swab should be collected from beneath the membrane, and it should be placed in a semi-solid transport media, as you can see in the bottom of the slide. And the semi-solid transport media can have the Ames or Stewart type of media. And if a piece of the pseudomembrane is collected, it can be placed in a sterile plastic container, and then it should be transported immediately to the lab. If there's a bit of delay in the transport, the samples must be kept at 4 to 8 degrees. And it's very important to know that the number of Corynebacteriums in the patient sample is usually small. There isn't a lot of bacteria in the patient sample. So it's really very important to protect the sample, transport it to the laboratory as soon as possible, maximum within 2 to 8 hours. And then if there's an extended transient time, maybe we can use the silica gel packs to protect the sample and the bacteria inside. Now, the WHO introduced the diphtheria manual that the talk that you are hearing today is based on it. And the diphtheria manual was released in 2021, and it has a very nice algorithm for how the laboratory can work with the samples that are suspected of having Corynebacterium diphtheria. So I want to take you through this algorithm. Then in the next few slides, we'll show you each step as it presents in the lab. So it's recommended for the original sample or the primary culture to be inoculated in the laboratory on 5% sheep blood agar, on the selective agar holystyrate, and if possible on Tinsdale agar. Suspected colonies of diphtheria has very different morphologies. and it can have a gray color, they can have a black color, and it depends on the media that we use and on the biovar that we talked about. So the colonies will have different colony morphologies, and after we have a suspected colony, it will be cultured on a 5% blood agar to make sure that the laboratory will start processing it and identifying the bacteria. Now, in the clinical laboratory, we can do on the isolated bacteria, the suspected colonies that we isolated, the gram stain, and we will show you the gram stain, how it looks for Corynebacterium. We can do manual testing with different biochemicals. We can do semi-automated methods, automated methods. And in case a sample needs to be referred to a reference lab, they can do more advanced laboratory diagnosis, such as multi-TOF. They can do the toxin, they can test for the toxin with the ELIC test, with the molecular diagnosis with the PCR. They can do antimicrobial susceptibility testing and a molecular typing of the bacteria. So now let's go through the steps in the laboratory and how the laboratory can work and what we anticipate that we see in the laboratory if we have a suspected Corynebacterium diphtheria. First, we have to streak the primary sample, the patient sample, as soon as possible on the appropriate agar that we talked about and incubate it at 37 for 18 to 24 hours. And the positivity rate of the culture, it can fluctuate from 5 to 20% depending on the study. And remember, it's based on the appropriateness of collecting the sample and the transport. And remember that the patient samples might have few number of viable bacteria. So on 5% sheep blood agar, the bacteria can have a gray or waxy looking morphology. And this is how it will look on 5% sheep blood agar. If we look at the holystyrate agar, the selective agar that inhibits the gram negatives and the good number of the gram positives, and the diphtheria is isolated on it, it can have a black or glossy looking appearance on this agar. If the sample is inoculated on the Tinstill agar, the suspected colonies can have a black with a brown halo, as you can see in the plate on the right. So this can give an idea about how Corynebacterium diphtheria look like. Now, in the beginning of the talk, we also mentioned that the diphtheria can have different biovars, different biochemicals, and different physiological or phenotypic types. So if we look at Corynebacterium on holystyrate, they can have different types of colony morphology with different colors. And here it's very important for the laboratory technologists to make sure that when they work with the bacteria, they don't misidentify it, because depending on the biovar, it can have different type of colony morphology, as you can see in the slide. The mitis, for example, it has a black colony. Gravis can have an opaque color, and intermediates can have also a black color. So it's important to technically to make sure that we understand the type of colony morphology the bacteria can produce. Now we isolated the bacteria. How we can identify it? Once we isolate the bacteria, we can do a simple gram stain on the isolated colonies. It takes about 15 to 20 minutes, and it's a gram. The Corynebacterium is usually a gram-positive bacilli. It can have straight or club rod shapes, as you can see in the graph. Some of them can have V formation, as you can see in the gram stain on the right. And some of them even can have what's called the Chinese letter formation. This can give you an idea that you are working with Corynebacterium. It doesn't mean that you're working with Corynebacterium diphtheria, just the genus that it's Corynebacterium. Also, laboratories can do Albert stain. It stains for the metachromic granules, and it just tells us that this is a Corynebacterium. As you can see in the slide on the right, the metachromic granules are stained. So once we get an idea that the bacteria that we isolated, it can be a Corynebacterium, we can do a catalase test, which is known for Corynebacterium to be positive. And then we can do biochemical tests. The laboratory can do a series of biochemical tests, including cystinase, pyrimidinase activity, alkaline phosphatase, nitrate reduction, urea hydrolysis, and a series of carbohydrate fermentation. The WHO manual has a very nice table that shows the different results that can be obtained for the different manual tests that can be done to identify Corynebacterium. And this we will share the link with you at the end of the talk. So these are doing a manual identification of Corynebacterium. At the same time, we can do more rapid and semi-automated identifications. There's very famous kits that are present that can identify Corynebacterium. For example, the API, the Analytical Profile Index API from bioMérieux, it can identify Corynebacterium. It can and it can identify the different species, Diphtheria, ulcerans, and pseudotuberculosis, and it takes about 18 to 24 hours. Now, in general, the API, it's a strip that has many different reactions. As you can see in the top, this is just a strip that is positive for everything, just to show the color change. And the one below it is the negative test. This is how it comes from the company. It's negative for everything. Now, the semi-automated systems, they are pretty cheap, not very expensive. They can also identify the Corynebacterium biovar that is present. So, for example, in an outbreak, you can have one or two biovars circulating. So you can do the semi-automated method with the Corynebacterium. It will identify the biovar that you have. For example, if you look at the top API, you can see glycogen is positive for Graves and it's negative for mitis, for example. So this is a very quick way that you can use in the laboratory to identify Corynebacterium at its species and the biovars. Of course, automated systems are present and are available to identify Corynebacterium. You can use the Vitek, for example, system for bioMérieux, BD Phoenix you can use, MicroSeq you can use to identify Corynebacterium at the genus and the species level biochemically. Also, there's the multi-TOF. This is you identify the bacteria based on the protein structure and protein profile of the bacteria. It's a very quick method to identify the bacteria. Takes maximum 5 minutes to identify the bacteria, but the startup cost and the preventive maintenance that is needed on the machine, it's really very high. So the cost per machine varies between $50,000 to about $250,000 depending on the machine, and the cost per test ranges between $5 to $50. And these are the different ways that we can use to identify Corynebacterium. After we looked phenotypically at the bacteria, of course, molecular diagnosis is available. And the WHO manual has a very nice a multiplex assay that can detect a real-time PCR assay. It can detect Corynebacterium diphtheria, Corynebacterium ulcerans, pseudotuberculosis, in addition to the Corynebacterium tox gene, with an internal control to make sure that the process was performed correctly. So this assay can be used. Again, it's a multiplex PCR. It's real-time PCR. It takes 4 to 6 hours to perform. And you can run a large number of samples each time, from 96 up to 384 samples each run. So molecular diagnosis can be used to identify the species of Corynebacterium and the presence of the tox gene. But we will talk about the presence of tox gene and what we need to do if it's positive by molecular diagnosis. Now, the important thing that in addition to identifying Corynebacterium diphtheria is to understand and how we do the sensitivity testing all our colleagues, they talked about sensitive Corynebacterium, drug-resistant bacteria, to penicillins, to erythromycin, and so on. So performing accurate antimicrobial sensitivity testing is very important in the management of the patients. We have to follow guidelines, and there are two guidelines that are available, one from the Clinical and Laboratory Standards Institute, CLSI, from 2015. It has guidelines that are for broth microdilution, and there is no guidelines or interpretation guidelines for disc diffusion. But the European Committee on Antimicrobial Susceptibility Testing, the UCAST, it released in January 1st, 2023, guidelines for doing both disc diffusion and microbroth dilution. So we have guidelines that we need to follow to make sure that we interpret the results of the sensitivity test correctly. So for example, the UCAST, it clearly specifies that if you want to get accurate results for if the bacteria is sensitive and resistant to a specific antibiotic that is part of the panel on this reference, it must the sensitivity testing must be performed on Mueller-Hinton with 5% defibrinated horse blood. So horse blood must be used, and this is the blood that is a supplement that must be used in order to obtain interpretable results, in addition to adding NAD to the agar. You incubate the sample, and then you read the sensitivity testing. Technically, it's really very important to my fellow technologists to remember that we cannot put multiple discs on the plates. We have to put a good number of tests, maximum 4 discs. And the reason for that is that if you look at the zone that the bacteria might produce, for example, for penicillin or for Cipro, for example, the zones are very large, about 50 millimeter. And if you have 2 discs besides each other, they will merge together, and then you cannot interpret the results. So technically, it's very important to follow the guidelines in order to obtain accurate ASTs, because a lot of decisions are being made after you do the sensitivity testing correctly. The WHO released in 2021 guidelines for released the guidelines from the CLSI and the UCAST, and it has the breakpoints. And I thought also to share with you that also the UCAST has clear guidelines that were released in January 1st. For example, if you look at penicillins, it has clear guidelines for what is sensitive based on the microbroth dilution and based on the disc diffusion. So it's really very important for our colleagues to follow the guidelines, to follow them correctly, to make sure we build good understanding on the results of the Corynebacterium diphtheria sensitivity testing. And I want to remind everyone that when we do sensitivity testing, we have to make sure that we do good quality control. After we do the sensitivity testing, we have to remember there are multi-drug resistant organisms, as our colleagues mentioned, but really we have to do ASTs, especially if we use erythromycin instead of penicillins. Our colleagues talked about the detection of the toxin. The ELIC test can be used, and basically the ELIC test is immunoprecipitation of the toxin that is produced by the bacteria with the antitoxin that is present. So if you look at the graph, in the middle is the antitoxin. The antitoxin diffuses in the agar, and the bacteria is like a clockwise around it. The toxin starts moving in the agar, and where they meet, there will be a line. This is the immunoprecipitation. Of course, we can do the toxin detection by qPCR. It takes 4 to 6 hours. And in outbreaks, instead of doing the ELIC test, we can use the PCR to look for the toxin. But we have to always remember that there are the non-toxigenic toxin gene-bearing strains, that these strains are positive by PCR but negative by ELIC, and we have to keep these in mind. In order not to take a lot of time, just to mention that molecular typing can be performed in order to understand the clonality of the circulating strains, to make sure what type of strains we have. different methods are present. Multi-locus sequence typing or whole genome sequencing can be used. It will give us an idea about the clonality and the type of strains that are spreading in and out. My last slide will talk about population immunity, and this it's important to remember that in order to understand if a population is immune, you need to understand if the population has a protective antitoxin level, and this can be done with the toxin neutralization assays. These are very labor intensive. And now there's our EIA assays or enzyme immunoassays that can be used, and there's very good correlation between them. And a individual is basically immune if the level is more than 0.1 international unit per ml. So these can be used to look at the population immunity. So to summarize, diagnosis of diphtheria is highly dependent on collecting the appropriate sample. Please, when we discuss patient specimen collection is so important. Collecting the appropriate sample is very important, and transporting it to the lab, it's also very important, because we have to remember that patient samples have small number of bacteria, and we need to protect them in order to be able to culture them in the lab. Culturing and antimicrobial sensitivity testing takes about 3 days, and resistant strains are emerging, as we've heard. And we can perform the toxin detection. It takes about a day, whether we do it by ELIC test or the toxgene. And I have at the bottom, we have at the bottom links for the WHO manual, WHO surveillance standards, and the UCAST, and we will share them with you in the chat. And thank you so much.
Wow, great. Thank you so much, Dr. Musa. So much information to give, but time is not our friend. I'll just read one of the question and answer chat for you to answer before we move on with the next presentation. This comes from Mary Boyd. The question goes thus: have any countries pioneered PCR diagnostics in direct samples? It's not isolates. We are exploring activating this in Nigeria soon. I would appreciate perspectives on any other countries that may already have it up and running with this outbreak. If you could just answer this question shortly.
Yeah, you know, the diphtheria, there isn't a lot of outbreaks that happened throughout the past years, but people have tried to look and use PCR on primary samples. It has been done, and the WHO guidelines can be used to look for the bacteria directly from patient samples. But it's very important to collect the appropriate sample and transport it to the lab appropriately without delays in the transport.
Okay, great. Thank you so much, Dr. Musa. So maybe just go to the Q&A section to answer some of the lab questions directed to you. So we'll move to the next presenter. That'll be Dr. Rashidatu Kamara. She'll be taking us on case management. Over to you, Dr. Rashidatu.
Thank you, Dr. Olaolu, and hello, everyone. Let me add my voice in thanking you for joining us as we discuss response strategies of the various pillars to the diphtheria outbreak in the region. My name is Rashidatu Kamara, and I coordinate case management activities for the diphtheria outbreak in the WHO Africa region. So as we have heard, we are seeing a resurgence of diphtheria, and this is quite alarming. We've also heard about the various species, but then mainly human infections are caused by Corynebacterium diphtheria and C. olceran. Transmission is spread mainly for C. diphtheria in crowded environments, in conditions where there is poor hygiene, and in areas where vaccination is low. C. olceran is mainly found in cattle rearing communities, and I think this could bring some sort of highlights as to where we are seeing these outbreaks. Transmission is mainly through coughing or sneezing, or when somebody comes in contact with the fluids. And so we know that it is easily transmissible. And we also have the non-toxigenic strains. C. diphtheria is a toxin-producing agent. The non-toxigenic strain has been associated with splenic and hepatic abscess and also some form of sepsis. Let me make this clear that everybody can be infected. However, the disease occurs mainly in children under 5 years of age, and both sexes, male and female, are equally affected. In populations where there is a high rate of immunization and improved coverage in children has shifted the age distribution. So we'll see some of people reporting in young adults and different age groups. So now for the clinicians on the call, what we'll need to know are the symptoms. And if somebody comes in with suspected case of diphtheria, these are the symptoms that you'll be looking out for. It resembles upper respiratory illness. So you'll have your flu-like symptoms, and then you'll have bloody nasal discharge. The patient could come in with a hoarse voice. There could be cough, or the patient will complain of difficulty in swallowing, or there is pain when the patient swallows, and there will be drooling or pulling of secretions, especially in children. On my right is a picture of a child. This is referred to as a bull snake. You'll see the swelling of the cervical gland. In severe cases, the patient could present with stridor, inspiratory stridor. There could be shortness of breath, fever may or may not be present, and then you would see in some cases the classical lesion of the ulcer, which is mainly referred to as dirty ulcers because they have this gray waxy pseudo membrane. Now, mainly we've heard about this pseudomembrane, and a classical way to differentiate this pseudomembrane from other pseudomembranes that can be caused by other bacteria is the fact that it is adherent, it sticks, it does not come off. In other cases, for instance, like Candida, if you happen to wipe off the membrane, it comes off easily. But in this case, it doesn't come off at all. And you'll see it at the anterior nasal or the pharyngeal or tonsils, or you could see it in the larynx or also in the trachea. So the first thing you need to understand as clinicians is to understand the history, and mainly what we are looking at aside of the symptoms which we have described is the history of contact. This could be one of the definitions, probable definition. If the patient has the symptoms that we have described and that patient has a history of contact in less than 2 weeks, then that patient automatically becomes a probable case. And then that patient has a pseudomembrane, etc. That patient automatically, like I said, becomes a probable case. And then you'll need to find out the history of immunization, when this patient was immunized, and how many shots did this patient take. These are things that we'll need to look out for. And then on examination, you'll need to check the temperature. As I'd already highlighted, there could or there couldn't be fever. You'll see swelling of the cervical lymph nodes. You need to inspect the pharyngeal walls, the uvula, the tonsils, the nasal antrum to see if there is any pseudomembrane. And then you look at the skin for the dirty lesions. Now we'll need to administer treatment, which is very critical. And the treatment of choice is actually the diphtheria antitoxin. In addition to that, you'd have to give antibiotics, which would be given based on the age and the weight, and also the susceptibility of that antibiotic to the strain. So now let's discuss steps to case management. When you have a suspect or probable or even a confirmed case, the first thing you need to do is to isolate that patient. And then you need to apply standard precautions plus this, droplet precautions and also contact precautions. Our colleague from IPC will be talking in details on this. And then you need to consider that sensitivity test. If this is not available, then you continue. If you do have the DAT, you would need to administer as soon as possible. We are kindly encouraging you all, do not wait for culture to start treatment, because culture, as we've seen, takes a while, 6 to 10 hours or 8 to 10 hours. And then you need to administer antibiotics. Repeatedly, we've had the widely spread resistance to penicillins. So the macrolides are now being recommended. You start your treatment very early. Again, don't wait for the AST. The AST would come after, and if there is any resistance to the drugs that you have initiated, then you can always change. But also let's be mindful of antimicrobial or antibiotic resistance. And then you would need to monitor your patients closely for any complications. Again, we are advising that vaccines should be provided appropriately to patients if not vaccinated. So now we've had several questions on the use of that and the administration of that. And to reiterate again, you give that immediately to any suspect or probable or confirmed case, especially when that patient has symptoms such as sore throat, low-grade fever, and the presence of the pseudomembrane. And administering that requires basic critical care, which is a high enough clinician to patient ratio so as to enable continuous monitoring of the patient. And during the infusion, the staff should be adequately trained prior so as to pick up, to identify adverse reactions and to be able to readily give emergency drugs. And then we should also be able to have rapid point of care diagnostics. But then again, in low income settings, these are not widely available. So continue with your administration of that. However, because of the low availability of that in the region, patients needs to be prioritized. So you would have to choose the class of patient that you're going to give that, and you would prioritize based on severity of the disease. So each ampule of that contains about 10,000 international units. And the first thing, like I said, you need to set up an acute care ward, maybe a HDU unit to administer the DAT. And then in most cases, you need to pre-medicate the patient so as to prepare them for adverse events with steroids or antihistamine. And then before administering that, kindly take a serum sample so as to send to the laboratory. That is given in about 250 to 500 mils of NS. You calculate the amount of that the patient needs, and then introduce it into the normal saline, and then it should be given for a period of between 2 to 4 hours. So it's very slow, it goes in very slow. And then close monitoring of the patient for adverse events. If the patient has no adverse event, then you can transfer the patient to a general ward and continue to observe for about 6 hours. By the 2, if the patient is stable, you can discharge the patient home to continue the antibiotics. There's contraindication to that in pregnant women, so do not give that to pregnant women. So this is a table of the type or the site of diphtheria, that is the pseudomembranes, and then the dosage, and then the route of administration. So you have the nasal or nasopharyngeal, you give between 10,000 to 20,000 if the pseudomembrane is in the nasal antrum and the route is IM intramuscular. Nasopharyngeal, you give about 40,000 to 60,000, and it's the same route. The tonsillar, you give between 15 to 25,000. You can either give IM or IV. Pharyngeal, it's between 20 to 40,000 IM or IV. And then if there is delayed diagnosis, that patient presents beyond 48 hours or after 48 hours, then you need to increase your dose and you give IV. And also if there is an extensive disease, then you need to give about 80 to 100 IU, 100,000 IU of that IV. So for antibiotics, like I said, again, this is something that we keep reiterating: start as soon as possible and do not wait for the AST. It is actually not a substitute for that, but then it prevents more production of the toxin. It slows the spread of local infection, and it reduces the risk of transmission. So the choice of antibiotic depends on the availability, but essentially on the sensitivity. Again, penicillin, we've seen a lot of resistance to penicillin. So maybe we would like to discourage at this point the use of penicillin in areas where there are high resistance to penicillin. So based on the disease severity, the patient is less ill or less sick and is able to swallow, we can use oral erythromycin. Yes, in cases where there are not many resistance to penicillin, you can use penicillin. However, if there's resistance, then you proceed with the macrolides. And again, you can use azithromycin and oral clindamycin. On my extreme right are the treatment dosage. So the treatment should continue for a period of 14 days. If the patient is discharged after day 2, the clinicians must ensure that the patient completes the duration of treatment, which is 14 days. If the patient is severely sick, then you would have to give IV, and the dosages are again on my extreme right. The presentations will be shared to you after the trainings. So now several adverse events have been noted with administration of that, and they include anaphylaxis and swelling of the face. There could be cough, oxygen desaturation. You could hear the patient wheezing, generalized rash or localized rash, itching, nausea and vomiting, listlessness or restlessness. You should be able to manage these patients appropriately. So what you need, you can give epinephrine, you can give the steroids, you can give nebulized salbutamol, you can give oxygen, and also IV fluids. If there is an anaphylactic shock, clinicians should ensure that you give IV adrenaline between 0.2 to 0.5 mils. So now you need to look out as you manage your patient, you need to look out for the complications. And if there's an obstruction of the airway or there is a circulatory collapse or failure, then please call for help so that that patient would be managed appropriately. So in the early phase, if there are complications, what you'll see, there will be edema, there will be swelling of the face or maybe the trachea. This could most likely be due to the pseudomembrane or even the fluids. Remember, you can have drooling in children. And then this could eventually obstruct airflow and the patient could become cyanosed, or it could lead to suffocation. By week 2, after the initial pharyngeal phase, some patients may develop myocarditis, and this is something that you need to follow up with patients for as well. And between 2 to 6 weeks, the patient could come down with neurological dysfunctions. There could be motor weakness or paralysis, and also the patient could have renal failure. However, airway obstruction and myocarditis are the main causes of death. So the patient needs to be observed critically for up to 48 hours of treatment. And then if the patient is stable, you will have to discharge home, but ensure that the patient continues the antibiotics for 2 weeks. And then patient is said to be negative when the culture comes out twice as negative. And then we would need to clinically assess and follow up on all contacts, and this should be kept on the surveillance for about a week. And we also encourage the administration of antibiotics as prophylaxis to contact. And what is usually used, this is from the 2017 Cox-Bazar outbreak, and they were using benzathine in children and adults, and then oral erythromycin. The dosages are there, and these should be given for a week, and also oral azithromycin, also given for a week. And then you need to assess the vaccination status of exposed close contacts, and if they are not vaccinated, you need to encourage them to take the vaccines. I think this is my last slide. I thank you all for listening.
Oh, great. Thank you so much, Dr. Rashidatu, for taking us through the principles of managing cases. I really appreciate all that. So colleagues, your question and answer, put it in the Q&A chat. Our panelists are answering those questions there, as we may not have time for oral responses. So we move to the next presenter, that is Dr. Deborah Barasa, who will be taking us on infection prevention and control regarding diphtheria. Over to you, Dr. Deborah.
Thank you so much, Dr. Olaolu, and thank you, colleagues, for having me here today. I don't know if you can see my slides, Dr. Olaolu.
Yes, your slide is visible. Carry on.
Yes. Thank you very much. So I will talk about infection prevention and control for the diphtheria outbreak. And I would also like to acknowledge the rest of the team who supported in the development of the slides, Dr. Landry Kabego, who's our IPC team lead, and also Ms. Tendai Makamure. So I'll move to the next slide. So my outline, I'll talk about diphtheria transmission cycle and the importance of IPC, the minimum IPC standards in a healthcare facility, IPC at household and community level, and the rapid assessment tool for respiratory pathogens, which we will be advocating for during the infection of diphtheria or during the diphtheria outbreak. So as alluded to by my colleagues, Dr. Thierry, Dr. Rashidatu, and the rest of the team, diphtheria is an infectious disease caused by the gram-positive Bacillus Corynebacterium diphtheria. And I think Dr. Yaya talked about the bacteria being club-like and also causing the pseudomembranous effect, which is the leather form, and that is where the name comes from. So as discussed, it causes respiratory disease. So the nasopharyngeal and the larynx are involved majorly. And later on, you could have systemic infections, as Dr. Rashidatu has talked about. And then there's the cutaneous disease, which can occur, as well as asymptomatic carriage, which has also been covered. And so for us as infection prevention and control, we are really talking about the modes of transmission and how we can prevent transmission through the various manifestations. So we'll talk about the chain of transmission. So as we said, the infectious agent is the Clostridium, is the Corynebacteria diphtheria. And the reservoir, it usually inhabits the mouth, the nose, the throat, and there's a cutaneous disease that can occur from the infected wounds. So causing through direct and indirect contact, one may get infection. The point of exit is through the respiratory droplets from infected persons, so through sneezing and coughing. And the modes of transmission, as said, can be direct or indirect. So for direct, through respiratory droplets, and cutaneous, as well as indirect through cutaneous. So contamination of the environment can actually propagate infection. Point of entry, respiratory tract, skin, and mucous membrane. So the bacteria attaches through the mucous membrane and gets into the system, as well as the point of entry can also be through breech skin. So suspected hosts, susceptible hosts are usually the unvaccinated. And I think the vaccine pillar will talk about the core importance of vaccine during the outbreak, and really as a continuity of continuity of vaccination in order to protect the community. So for an infection to spread, all links, for an infection to spread, we need to have a breakage in the chain of infection. So when we have a breakage, breaking one of the links, for an infection to spread, we need all chains, all the links to be connected. And when we break one of them, then we break or stop transmission of infection. So we will talk about how we can stop that as infection prevention and control team. So I really like this slide because it talks about standard precautions and transmission-based precautions. So we say as IPC, standard precautions are really the core of infection prevention and control. Whenever we are in a healthcare facility setting, these are the heartbeat of IPC that need to be in place as a bare minimum. And then for transmission-based precautions, these are precautions based on the outbreak at hand. So this time we are dealing with cholera. Maybe next time it will be Ebola. Maybe next time will be, this time we're dealing with diphtheria. It could be cholera, it could be Ebola. So transmission-based precautions are really based on the microorganism at hand. So for the standard precautions, as we said, these are the bare minimum. For instance, hand hygiene. And if we have IPC focal points in the group, you will agree with me that hand hygiene is really one of the mainstay of IPC infection prevention and control practices within a facility setting. And also for diphtheria, we also talk about hand hygiene, because when we have contaminated hands and we are touching the mucous membrane, the nose, throat, the mouth area, and then that could also lead to propagation, infecting ourselves, and also propagating infection within the facility setting. Again, respiratory hygiene is also critical, especially for the diphtheria outbreak. And this really involves, covering our mouth or coughing on a flexed elbow, discarding the tissue within, ensuring that there's proper waste management and discarding of the tissue appropriately, and then again, washing our hands appropriately during as we practice a respiratory etiquette. Also, the PPEs that are used are based on risk. So we are not just saying a PPE for respiratory or contact precaution, but for standard precautions, we are saying PPEs based on risk. Whatever risk is at hand at the facility setting, then we use the appropriate PPEs that are needed. Again, safe injection practices and sharps management. And you will all agree with me that injection practices in diphtheria is really critical. Dr. Rashidatu has talked about instituting IV, IM injections, and also the vaccine pillar will have also the vaccination of the community, vaccination within maybe for the health workers, among others. So injection safety, again, is a critical role that we need to strengthen for diphtheria outbreak. Again, safe handling, cleaning, and disinfection of patient equipment so that we avoid cross-contamination among patients, and environmental cleaning, as well as linen management and waste management. So I think we are all in agreement that in whatever facility we are dealing with, whatever outbreak we are dealing with, standard precautions are really the bare minimum that we need to have for whatever outbreak we have. But now when we come to the diphtheria outbreak, then transmission-based precautions are an addition to the standard precaution. And in this case, as my colleagues alluded to, the respiratory and contact precautions come into play based on the modes of transmission. So isolation of the case is really critical in this case. And then we need to have signages and posters that are looking into respiratory and contact precaution. We'll talk about that. And then PPEs that are specific to the diphtheria outbreak. And then we need to have dedicated materials and equipments and other cleaning measures to ensure that even as we are seeing patients, we may have disposable equipments, but in case we are using the same patients, then we have to have cleaning measures between the patients. Again, transportation and movement, we'll talk about that as well as communication. So in order to sum this up, for standard and transmission-based precautions, we as a IPC advocate for the multimodal strategy, which is we build it, we teach it, check it, sell it, and leave it. We need to build a system like for hand hygiene, ensuring that we have hand hygiene facilities, we have masks available, we have gloves and other PPE equipments, yes. We need to teach, we need to train our health workers on how to really strengthen this standard and transmission-based precautions. And then we need to check it, which we'll talk about again further. We need to keep on monitoring IPC practices within the facility, give feedback to the health workers who are the end users, as well as at a strategic level, the stakeholders, which will help us improve IPC capacity within the facility. We need to sell it. We need to have reminders and communications. And again, we need to live it. That is, have a culture of change. Yeah? And you'll all agree with me that COVID has just, COVID now has really declined, but we had IPC practices during that. And it seems like we have all forgotten it. So how do we ensure that we have a lifestyle of IPC practices within the facility to prevent health worker infection and even extending to the community? So at a triage and admission level, we need to, as we said, immediately separate patients who have upper respiratory tract infection. So what are we saying? When the patient enters into the facility, let us look for symptoms of upper respiratory tract infection. Let us separate them from the rest of the patients coming into the facility, because these are the ones who will actually propagate infections. And maybe they will actually cause infections among the susceptible hosts, like the children, the immunosuppressed cases, among others. So let us ensure that we screen and we are separating. And then when we have a suspected case, then we need to admit to an isolation treatment facility. Yeah, preferably a single room. Let us not mix our patients up. And if this is not possible, then we cohort the patients in confined areas, keeping suspect and confirmed cases separate. Yeah, so that would prevent propagation of infection. And again, we will talk about monitoring. We need to see how many cases have actually developed infection within the healthcare facility, how many health workers have developed infection, because this would be an indicator of the IPC capacity within a facility setting. Again, we need to keep the isolation area segregated from other patient care areas, and maintain a 1 meter between each patient. And patient care areas will really need to be well ventilated. The disease is usually not contagious after completing 48 hours of effective antibiotics. And in this case, as Dr. Rashidatu had said, we can consider discharging of patient if the patient is clinically stable. So again, a repetition. Diphtheria is respiratory, that is contact and droplet precautions need to be adhered to within a healthcare facility. And we need to really ensure that the staff who are entering within this ward or the area where we are isolating the patients are informed about the IPC practices. So which ones are these? Contact precaution, hand hygiene, okay? And then PPEs, appropriate PPEs for utilization. For respiratory, we say we cover our eyes, mucous membrane, our nose, our mouth. So we wear a mask, and our eyes, we wear, a shield or goggles. And then we wear the gloves and again, the gowns for protection. Again, when we are transporting the patients, we say, let's limit the movements, but if we need to, then let's ensure that the patient is wearing a mask, and let us strengthen cleaning and disinfection at least twice a day in the facility setting. Again, emphasis on a single room with good ventilation or cohorting the patients. So we can use this poster in each ward where we are isolating patients, so that everyone is informed. And again, let us ensure that the appropriate PPEs are accessible to all health workers who are entering into that isolation area. So again, emphasis on the droplet and contact precaution. As we said, isolate the patient, avoid patient movement, but if you need to, let the patient wear a medical mask, and then let us have 1 meter distance between patients. For family members, at times you may have a child, as Dr. Rashidatu had said, the preponderance is among the children. And so you can have a mother stay with the child, but then let us ensure that there are appropriate IPC practices. There's health education for the family member on IPC practices, including hand hygiene, medical mask use, ensuring 1 meter distance between, but if the mother needs to come close to the child, then they use a disposable gown, eye protection, and gloves, among others. And let us give prophylactic antibiotics to family members, and also inform them about vaccination. So for health workers, as we said, hand hygiene is critical, wearing medical masks, and again, wearing the appropriate PPEs based on risks. So when within 1 meter, we recommend wearing gloves, eye protection, and long-sleeved gowns for examination, specimen collection, among other procedures while servicing the patient. Again, we need to remove PPEs after contact with the patient, and then perform hand hygiene and dispose of them appropriately. And for each patient, we need to have dedicated equipments, but if this is not possible, then we need to clean and disinfect between the use of patients. And we need to refrain as health workers from touching our eyes, nose, and mouth, because with contaminated gloves or ungloved hands, because of risk of transmission, and encourage hand hygiene, as we said. Again, indirect contact, so contamination can occur within the facility, like the doorknobs, the light switches, and the mobile. So cleaning and disinfection is really critical, and we need to avoid contaminating the surfaces as health workers. So again, strengthening the multimodal strategies for this contact and droplet precaution, that is building it, teaching it, checking it, selling it, and living it. So as IPC focal points, let us ensure that we are having that in place. So what are the PPEs we can use in the triage area? Face mask, but as we said, it's again based on the risk. We need to conduct a risk assessment before using the appropriate PPEs. So what am I saying? Suppose a patient vomits, then it's not just the medical mask that you'll be using. You may require other PPEs for that case. For instance, gloves, a gown, or if you fluid resistance, then you may need to have an apron, etc. Then when we are performing examination, procedures, and transportation of patient, then we need goggles or face shields. We need a medical mask, gown, and gloves. And for any aerosol generating procedures, Dr. Rashidatu had talked about upper airway obstruction, and so we may need to have some procedures in this case. Then you need to use the appropriate PPEs. And in this case, goggles or face shield, a respirator, gowns, and gloves are recommended. So you can see there's quite some similarity with the COVID-19. But now the practice is where the challenge is. And so we need to really strengthen the multimodal strategy to ensure that our health workers are using appropriately. So 5 moments of hand hygiene, I believe we all know. 2 befores, 3 afters. So before touching, before cleaning or aseptic procedure, and then after touching the patient, surrounding, and after body fluid exposure and risks. And then we need again to teach them on the hand hygiene techniques for alcohol-based hand rub and also for hand washing. And this we encourage, again, the multimodal strategy. You can see me emphasizing this because it really strengthens the behavioral practices within the facility among health workers. So we need to have like hand hygiene stations and also soap, alcohol-based hand rub. We need to teach our health workers. We need to monitor hand hygiene practices. We need to have reminders, posters like this, and have a culture change to ensure that IPC practices are adhered to. So there's the IPC facility evaluation tool, and this one is really an assessment tool in the facilities that it should be conducted in facilities managing diphtheria on a regular basis to determine how effectively they are adhering to the guidance. So this includes a detailed assessment of all IPC activities and practices, and really it's the COVID-19 rapid assessment tool that has been adopted and adjusted for the diphtheria outbreak. And then we can monitor and report routinely, frequently based on gaps. So you can have daily, weekly, and monthly assessment, and then from there you can have improvement plan, gradually improving IPC capacity within the facility which you are in. And why do we use it? We use it to assess the level of implementation of IPC measures, and when there is a confirmed, suspected or confirmed diphtheria case, and by who? By treatment assessors who have competency in IPC. So for countries that have the diphtheria outbreak, we would kindly recommend that you monitor and improve IPC practices by utilizing this assessment tool. It has the various variables, as you can see. We look at the IPC program. If you have a focal point, the screening and triage area, the isolation and waiting area, hand hygiene facilities, PPEs appropriate for the infection at hand. Now it's diphtheria, waste segregation and waste disposal. If the staff have been trained, if there's intra-hospital suspicious case alerts, sterilization, health worker exposure, water supply and storage, sanitation and hygiene in the healthcare facility. So multiple variables have been used, and we are happy to report that the tool was quite effective during COVID-19. And now that it has been adopted, we would really encourage you to utilize it within your facility, identify gaps, and see how we can support to improve IPC capacity. So what about IPC in a home setting? We know, as Dr. Rashidatu has said, patients will be discharged, and what we are saying is after discharge, we restrict contact with others until one has completed the antibiotic therapy. And during this time, we need to put the patient in a well-ventilated room, and we need to limit the number of caretakers who are coming in contact with this patient and maintain a distance of 1 meter from the patient if it's possible. We need to limit patient movement and minimize shared space, and the caregiver should wear a medical mask when in the same room with the ill person. We also encourage hand hygiene following contact with all ill patients, and routinely as IPC we encourage that, and also encourage respiratory hygiene at all times. Again, we avoid direct contact or use of disposable gloves when in contact with bodily fluids, and avoid other types of possible exposure to patients' contaminated items. The utensils and dishes are cleaned routinely using soap or detergent and water. And we clean and disinfect the frequently touched surfaces, the bathroom and the toilets with regular household disinfectants. Again, cleaning of the beddings and other things should just be done routinely. And also all households should be considered as contacts, and then we follow the policies as Dr. Rashidatu had talked or alluded to earlier. So that is it from me, and thank you very much for your time. Over to you, Dr. Olaolu.
Oh, great. Thank you so much, Dr. Deborah. Quite a lot to put in together in this 2 hours. So we'll quickly move to the last presentation, which is on immunization, which will be taken by Dr. Jose B.A. Hope you'll be able to do some summary to save us some time. Okay, over to you. Your mic is not, mic is still muted?
Yeah, do you hear me now?
Yes, can hear you.
Yeah, thank you very much, colleagues. In fact, I'm honored to share with you these few slides which were put together by colleagues in AFRO. I'm Dr. Joseph Bie, working at IST West Africa as routine and new vaccine officer. So for the sake of time, the slides are in English. I would quickly go in French just to try to kind of provide key, would say, takeaway and message on the immunizations component of these responses. I don't know if the slides can be displayed from your end. Oh, ok. Merci beaucoup, hein, collègue. Comme dit, je vais essayer rapidement parcourir ces slides qui ont été mis ensemble par le collègue de Brazzaville. Et donc, je suis José Bié, je travaille avec l'équipe interpays de l'OMS basée à Ouagadougou, au Burkina Faso, en charge de l'Afrique de l'Ouest. Slides. OK. Alors, je pense que, comme il a été dit, la bactérie de la diphtérie, justement, produit des toxines. Et je crois que ça a été clairement dit. Et ce sont ces toxines qui servent à la fabrication du vaccin que nous utilisons. Et par le processus d'inactivation de cette toxine. Le vaccin, il existe depuis les années 20 et c'est souvent une combinaison de vaccins. Au-delà du vaccin contre la diphtérie, il y a plusieurs autres antigènes qui sont en combinaison avec ce vaccin, mais c'est surtout les vaccins contre le tétanos et la coqueluche. Mais à cela s'ajoute le vaccin contre l'hépatite B et le vaccin contre le HIP. Et pour ce qui concerne justement la plupart de nos pays, nous sommes en train de parler du vaccin pentavalent qui est en circulation et en utilisation dans la plupart de nos pays. Le vaccin en lui-même est un vaccin quand même qui offre une sécurité et qui a une efficacité qui va au-delà de 80%. Et avec le fait que la mesure un peu du dosage de ce vaccin s'exprime par ce qu'ils appellent le limit of floculation en termes de dosage, avec le fait que ce dosage est plus supérieur chez les enfants que chez les adultes et chez les adolescents. Alors, ce qu'il est important de noter, c'est que quand on voit justement l'écriture des différents types de vaccins, vous allez noter qu'il y a des écritures où on retrouve la dose, en fait, le vaccin diphtérie écrit en majuscule, et il y a des écritures où on retrouve la dose de vaccin diphtérie écrite en minuscule. En fait, ce qu'il y a, c'est que quand c'est écrit en majuscule, c'est la formulation qui est recommandée pour les enfants. Et quand c'est écrit en minuscule, c'est la formulation qui est recommandée pour les adolescents et les adultes. Et pourquoi cela? C'est parce que justement, le dosage au niveau des enfants est plus supérieur qu'au niveau des adultes, étant donné que les adultes et les adolescents répondent mieux à la réponse vaccinale. Diapo. Slides. OK. Alors, donc, comme je vous l'ai dit, vous allez voir ici les différentes formulations justement avec ces différences en D capital ou en D minuscule. Et vous allez voir que là où il y a souvent les D majuscules, c'est le vaccin, comme je l'ai dit, qui est donné à un âge plus supérieur. Et là où il y a le D majuscule, c'est le vaccin qui est donné à un âge inférieur. Et donc, comme vous pouvez le voir, la plupart de tout ce qu'il y a comme D majuscule commence à partir de 6 semaines. Mais quand vous voyez les D minuscules, c'est à un âge généralement plus supérieur. Slides. Alors, quelle est la situation au niveau de nos pays dans la région africaine? Tous, nous savons que nous avons 47 pays. Et de ces 47 pays, la plupart des pays, ce sont des pays gavis. Alors, le calendrier vaccinal tel que rapporté dans les IGRF que les pays rapportent chaque année montre que pour la dose primaire, donc la série primaire de la vaccination, la plupart de nos pays, nous sommes au calendrier de 6, 10 et 14 semaines. Et ça concerne 34 pays sur les 47 de la région africaine. Mais il y a des différences avec certains pays. On voit justement que, par exemple, la Guinée équatoriale et les îles Maurice vont au-delà de 14 semaines et administrent une dose supplémentaire à 18 semaines. Le Burkina Faso et le Congo, on voit qu'au lieu de commencer à 6 semaines, ils commencent à 8 semaines et ils ont leur deuxième dose à 12 semaines et la troisième dose à 16 semaines. Le Cap-Vert commence à 2 mois, après c'est 4 mois, après c'est 6 mois et après c'est 18 mois. Les îles Seychelles commencent à 3 mois, après c'est 4 mois et 5 mois. L'Algérie commence à 2 mois, 4 mois et 12 mois. Le Botswana, 2 mois, 3 mois et 4 mois. Et l'Angola, 2 mois, 4 mois et 6 mois. Et l'Afrique du Sud, 6 semaines, 10 semaines, 14 semaines et 18 mois. Alors, par rapport aux doses booster, on voit qu'il y a très peu de pays qui administrent des doses booster. Ces quelques pays, comme vous pouvez le voir, ce sont les îles Maurice, le Botswana, l'Afrique du Sud, Namibie, Eswatini, Botswana, Gambie, Lesotho et Seychelles. Ce que vous pouvez constater, c'est que la plupart des pays qui administrent les doses booster, ce sont des pays non gavis. Et pour ces doses booster, effectivement, ils utilisent la formule de DT. Et là, effectivement, il y a l'Afrique du Sud qui utilise la formule T avec D minuscule. Il y a Namibie et Eswatini qui utilisent la formule T avec D majuscule et l'île Maurice qui utilise la formule TD avec P et IPV. Slides. Alors, par rapport justement à ce vaccin, c'est un vaccin qui est assez bien toléré. Il n'y a vraiment pas d'effets secondaires majeurs qui ont été décrits jusque-là, mais néanmoins, il y a quelques érythèmes au lieu de vaccination. Il y a le fait aussi que, effectivement, cette réaction, généralement, se résout après quelques jours. Il faut aussi, et ça je crois que je l'avais dit, le fait qu'effectivement, par rapport justement à la posologie, c'est le fait que chez les adultes, on donne le vaccin avec une faible posologie plutôt que chez les enfants, du fait justement que les adultes répondent plus facilement que les enfants. Slides. Alors, quel est le calendrier recommandé? Et normalement, il y a les position paper de l'OMS, il y en a eu un en 2006, le dernier date de 2017. Et ce qui a été recommandé, c'est évidemment la série primaire de vaccination. Et comme je l'ai dit tout à l'heure, la plupart de nos pays, justement les 34 pays, utilisent justement cette série primaire qui recommande de commencer à 6 semaines. Et après, 4 semaines après, bon, dans la plupart de nos pays, c'est 10 semaines après et puis 14 semaines. Donc ça, c'est la série primaire. Mais en plus de cette série primaire, il y a le booster. Et ce qui est recommandé, c'est qu'il faut donner justement ces doses booster, la première de 12 à 23 mois, la deuxième de 4 à 7 ans et la dernière de 9 à 15 ans. Et donc, l'intervalle normalement recommandé entre ces doses booster est de 4 années. Alors, dans le cas que l'enfant n'a pas reçu ces doses et que vraiment il y a un retard dans la vaccination, il est recommandé justement de donner 3 doses. Mais ici, vu le fait que l'enfant est plus âgé, il y a nécessité de voir quelle formule utiliser. Et en fonction justement du type de formule, avec le fait que la formule avec le D minuscule est à administrer chez des enfants d'un âge un peu plus supérieur, c'est ça qui est recommandé. Et la formule avec le D majuscule des enfants un peu moins âgés, c'est ça qui est recommandé. Avec le fait qu'il faut aussi ajouter 2 doses de booster maintenant par rapport à justement ces enfants qui sont plus âgés, au lieu de 3 doses booster, mais en faisant en sorte que ces doses soient espacées d'une année. Slides. Alors, donc, c'est un peu ça, ce qui ressort de la table de recommandations justement de l'OMS, parce que il y a des tables qui donnent par vaccin qu'est-ce qui est recommandé pour les enfants, pour les adolescents et les adultes. Et donc, ces tables sont disponibles, il suffit simplement de les consulter, il y a toutes les directives là-dessus. Slides. Alors, ça c'est un peu la situation actuelle de cette vaccination dans notre région. Comme vous pouvez le voir, et il a été dit, pratiquement, il y a des difficultés pour l'atteinte des performances requises en matière de cette vaccination. Et je pense que c'est ça qui fait que nous éprouvons encore des difficultés réelles par rapport à cette question de la diphtérie. Slides. Et là, c'est un peu plus de détails, pays par pays, comme vous pouvez le constater, avec le fait, bien sûr, ici, on a fait ressortir particulièrement la situation du Nigeria et de la Guinée. Bien sûr, il y a le Niger aussi, mais comme vous pouvez le constater, ce sont vraiment des pays où les couvertures sont encore très, très basses. Slides. Alors, par rapport justement à la vaccination et étant donné justement cette épidémie, il est nécessaire que rapidement les pays puissent mettre en place des mesures de vaccination pour réduire justement la population des susceptibles de manière à ce que nous arrivions à contrôler cette maladie. Ça, c'est la première chose. Et je crois que ça a été dit, il n'y a pas que les cas. Au-delà des cas, il faut voir quels sont les contacts et vraiment étendre la réponse en termes de vaccination de manière à s'assurer qu'on va au-delà des cas, mais qu'on s'étende au niveau des contacts et même aller au niveau des contacts de contacts. Bref, arriver à pouvoir vacciner le maximum si possible. Et ça aussi, il faudrait absolument que dans la planification de cette campagne, que l'on tienne compte justement de l'épidémiologie de la maladie, de la situation telle qu'elle se présente dans nos différents pays. Il a été dit, je crois que les collègues précédents en ont parlé, a priori, on a plus de cas au-delà de notre cible habituelle. Ça c'est la première chose, avec le fait aussi que les calendriers de vaccination, comme vous pouvez le constater pour la plupart de nos pays, il ne va pas au-delà d'une année. Donc, mais malheureusement, la plupart des cas sont au-delà d'une année. Et donc, il est important justement de faire le point de l'épidémiologie de la maladie pour pouvoir cibler les cas vaccinés. Ça, c'est un aspect qui est très, très important et je crois que ça a été relevé par les collègues précédents. Slides. Alors, pour ce qui concerne les stratégies vaccinales, bien sûr, ça dépend du contexte, ça dépend de la situation et ça dépend aussi des capacités logistiques de chacun de nos pays. Mais bien sûr, l'idéal, c'est de faire en sorte qu'on puisse vacciner dans les meilleurs délais, faire en sorte que les populations qui doivent justement être vaccinés n'aient pas assez de difficultés pour accéder au site de vaccination. Et donc, il y a nécessité de voir est-ce que ces populations sont accessibles ou pas. Si elles ne sont pas accessibles, nous devons faire l'effort d'aller vers eux, étant donné que ils ne peuvent pas accéder au site de vaccination. Il faudrait qu'on aille vers eux pour pouvoir leur fournir le vaccin qu'il faut. Et je pense que par rapport à ça, bien sûr, ça demande d'aller au-delà des sites fixes, d'aller dans les villages, dans les communautés qui sont éloignées et aussi vraiment des communautés, comme qui dirait, sont pour la plupart laissées pour compte. Slides. Alors, donc, vraiment, il est nécessaire, et je pense que ça a été dit, de voir en fonction justement de la cible, quelle est la formule du vaccin que nous devrions utiliser. Et pour la plupart justement de nos pays, nous avons soit le Penta, soit le TD. Et donc, il faudrait justement, tel que décrit avant, voir en fonction de l'épidémiologie, est-ce que nous allons utiliser le Penta ou nous allons utiliser le TD, en comprenant que le TD a le D avec minuscule et le Penta a le D avec majuscule. Et donc, ça, c'est la première chose. La deuxième chose, c'est quand il faut intervenir. L'idéal, c'est de le faire le plus rapidement possible et bien sûr, en regardant quelle est la cible à atteindre et par rapport à cela, voir aussi la question des susceptibilités. Mais bien sûr, il faut voir aussi exactement par rapport à notre programme, qu'est-ce qui a déjà été fait par rapport à cette vaccination. Est-ce que les enfants sont vaccinés? Si ils ont été vaccinés, jusqu'à quel âge on vaccine, en fonction justement de notre calendrier. Et donc, par rapport à cela, il y a vraiment nécessité de faire une très, très bonne analyse de l'épidémie pour pouvoir circonscrire effectivement la zone à pouvoir vacciner. Slides. Alors, très, très important, bien sûr, la nécessité d'une bonne planification. Et ça, je pense que pour toutes les interventions liées à la vaccination, que ce soit pour les campagnes que pour la vaccination de routine, ce qui est recommandé, c'est vraiment une très, très bonne planification. D'abord, bien sûr, au niveau macro, mais surtout au niveau micro. La micro-planification, on ne cessera jamais d'insister là-dessus parce que c'est vraiment l'élément clé qui permet la réussite justement des campagnes. Bien sûr, c'est cette micro-planification qui va déterminer toutes les ressources à mobiliser et donc elle est absolument indispensable. Nous savons que nous devons répondre à des épidémies, mais cela n'exclut pas que nous puissions faire une micro-planification pour permettre que nous puissions répondre efficacement par rapport à ces épidémies. Slides. Alors, bien sûr, même si c'est une situation d'urgence, il faut bien former les acteurs. La communication est une composante essentielle. Les MAPI sont une composante très, très essentielle, étant donné surtout qu'on est dans l'urgence. Il faudrait absolument qu'on s'assure effectivement que toutes les mesures sont prises par rapport à la sécurité des vaccins. Bien sûr, la supervision, le monitoring doit être mis en place pour pas qu'après la campagne ou bien après la riposte, qu'il n'y ait pas de données. Absolument. Il faudrait qu'on s'assure qu'on mette en place les mesures nécessaires pour qu'on puisse être à mesure après de pouvoir rapporter et de pouvoir montrer justement les résultats de l'activité qui a été conduite. Slides. Alors, bien sûr, il y a nécessité de bien mener ces campagnes, mais aussi de voir comment justement faire, même si ce n'est pas en tant que tel des évaluations classiques en termes d'enquête de couverture, mais au moins des évaluations rapides pour voir la qualité des opérations que nous avons mises en place. Et je pense que les pays ont assez de capacités par rapport à ça, avec toute l'expérience acquise avec les campagnes polio. Slides. Et donc, après la campagne, justement, sur la base de ces évaluations des résultats, il est nécessaire de voir s'il y a des poches, bien sûr, qui n'ont pas été bien couvertes, de pouvoir, bien sûr, conduire quelques activités de riposte, mais aussi, et je pense, la nécessité quand même, après ces campagnes, même si on ne peut pas conduire des enquêtes en tant que telles, mais que les gens puissent s'asseoir pour avoir un peu un regard sur ce qu'ils ont mis en œuvre. Ça ne demande pas beaucoup de jours, même en 1-2 journées. Vous pouvez vous asseoir pour faire un peu le point et réévaluer un peu toute l'activité telle qu'elle a été conduite du début jusqu'à la fin, afin de tirer les leçons et de pouvoir permettre de vous améliorer pour la prochaine fois. Slide. Alors, vraiment, comme leçon que nous pouvons tirer justement de cette situation que nous sommes en train de vivre, et au vu de ce que j'ai montré précédemment par rapport justement à la vaccination telle qu'elle se fait dans notre région actuellement, du fait justement que la plupart des pays sont encore à cette première série, il est nécessaire que, compte tenu des leçons tirées de cette situation, que les NITAC dans nos pays puissent s'asseoir pour revoir cette question de calendrier vaccinal. La recommandation de 2007 demande qu'on donne au-delà de la série primaire les doses de rappel. Et comme vous pouvez le voir, il n'y a que très peu de pays dans notre région qui offrent des doses de rappel. Et la plupart, ce sont des pays non Gavi, des pays qui achètent le vaccin par eux-mêmes. Et nous pensons que maintenant, les pays Gavi qui obtiennent les vaccins de Gavi devraient absolument faire l'effort pour introduire ces doses de rappel. Ça, c'est vraiment important. Deuxièmement, bien sûr, et cela a été dit par les collègues avant moi, il y a cette question des capacités en termes de préparation et de réponse par rapport à cette diphtérie. Et je crois que les collègues l'ont bien dit que maintenant, la diphtérie va être intégrée dans le cadre justement des maladies à surveiller. Et donc, il y a toute la problématique du date qui a été dite même avant moi. Mais je pense qu'il y a vraiment lieu que l'on puisse, même au niveau global, au niveau régional, réfléchir sur cette question de disponibilité justement de dates, avec le fait que, bien sûr, on a de plus en plus de cas de diphtérie. Mais bien sûr aussi, nous devons vraiment avoir cette ambition en nous disant que les mesures doivent être mises en place pour que cette question de décès dû à la diphtérie puisse être réglée, de manière à ce qu'au moins en 2030, qu'on puisse quand même arriver à montrer à la face du monde que la diphtérie ne constitue plus un problème pour nos pays. Slide. Donc, voilà les quelques ressources que nous pouvons partager et je pense que il sera bon que vous puissiez les parcourir et les approfondir. Je pense que je suis à la fin de ces quelques slides que j'avais à partager avec vous. Merci.
Merci beaucoup, Dr. Joseph Vie. Thank you so much for that presentation, and also to thank colleagues for still being on the call. Still have quite a number of close to 400 attendees still on the call at this time. You know that it's still a lot to discuss about and to learn about the diphtheria response, but this is just what we need to do for this period in time. I'd like to thank all the presenters. I will hand over to Professor Adebola Olayinka to wrap up this session for us. Over to you, Prof.
Yeah, thank you very much, Dr. Olaolu. Thanks to all our excellent presenters and also to our participants. We're grateful for staying long with us on this. We overshot our time by a few minutes, but I'm sure you'll agree with me that it's been worth it. And just also to tell you all that you get the presentations and the recordings in all the 3 languages in a few days following the end of this webinar. Now, having said all of that, there are quite a number of things that have come up with these presentations. People have asked, why are we having this resurgence in the disease? One of the reasons, of course, has been answered. There's decreasing immunization coverage. That reduces the herd immunity, and that increases the risk of transmission, the risk of the disease. In adults, the immunity wanes. We are also aware that the population moves. There's been a lot of population movement in the last few years. There's probably been outbreak spread to neighboring countries. And then in some countries, there's been an irregular supply of vaccines. But I want to emphasize that diphtheria is a vaccine-preventable disease. And so one of the greatest prevention measures is really to strengthen routine immunization, to strengthen, and countries would need to make strategic investments in this to ensure that they're able to strengthen their health systems. We cannot achieve universal health coverage when we have people still dying from diphtheria. I read in the Q&A that 2 children just died this morning from diphtheria, and that is really sad in this century. The other thing which the last presenter brought on board is for countries to go back and really to do a reassessment of their routine immunization schedules. Do they need to optimize it? Is there a need to add boosters? Is there a need to increase the number of booster doses? And I'm sure that as we go along in this year, these are some of the things that will be reviewed within the region and will be addressed. There's also the issue of the stockpile, especially now when we're having outbreaks. The vaccines that are being produced for routine immunization, some may have to be deployed for reactive vaccination. And so that causes a challenge in our stockpile. And we are looking at eliminating preventable death by 2030. This is 2023, we are close to the end. So it means we have roughly about 7 years to achieve these targets. I think this sends a lot of messages back to us as individuals, as organizations. What can we do? What do we need to be doing? What strategies do we need to implement? What do we need to be looking at? And how do we work on this? This is a preventable death. We all need to put our hands together to ensure that children are not dying from a vaccine preventable disease, and adults are also being protected. So having said all of this, I'll just thank you all for staying with us until this time. And we look forward to an improvement in the morbidity and mortality from this outbreak and a rapid control as we put in all the efforts necessary. Thank you, and over.